Hey guys, welcome back to another edition of the UK ICU Curriculum. Again, as a quick disclaimer, these presentations are designed to be short reviews of each of these topics. They're designed to complement your bedside teaching. They're not really designed to be long, expansive reviews, every subtle nuance of the topic. So without any further ado, let's get into it. Today we're going to talk about shock. If you remember from some of our previous presentations, shock is defined as tissue hypoxemia as a result of reduced oxygen delivery. There can be increased oxygen consumption or inadequate oxygen utilization, maybe even all three of those things. While there are some less common causes of inadequate oxygen utilization, such as, let's say, an inherited mitochondrial disorder, carbon monoxide, or cytotoxicity, in general, shock is most commonly as a result of circulatory failure and hypotension. That's kind of what we think of. Today's goals, you can see down there at the bottom, we're going to understand the definition of shock, understand the relationship between blood pressure, cardiac output, and vascular resistance. We're going to look at a framework to understand the different types of shock and how do we treat shock. These are just some boring abbreviations. If you want, you can pause and look at that. So what is the clinical definition of shock? It is basically low blood pressure. Usually we're going to say a systolic less than 90, a MAP less than 70, although keep in mind that some people, there is a little asterisk there, for some people who run at a high blood pressure normally, say if you're a poorly controlled, hypertensive, hypotension can also be a significant reduction in the patient's baseline blood pressure by 40 millimeters of mercury. So if you're normally running at 200 and now you're at 100 for systolic blood pressure, you might actually be in shock. Again, you need low blood pressure and signs of tissue hypoperfusion. So those can be signs of liver failure, new liver failure, cold or cool extremities, tachypnea, tachycardia, altered mental status, renal failure, or lactic acidosis. Okay, so as you recall maybe from the septic shock lecture, shock is basically cellular hypoxia. So what exactly determines oxygen delivery? We have this formula down here where we talk about the DO2, or the delivery of oxygen, and that is equal to the cardiac output times your hemoglobin multiplied by your saturation. That's basically how many red blood cells you have and how many of those red blood cells are saturated with oxygen. This 1.34 is just a little correction factor for how much oxygen is carried in 1 liter of blood. And then over here, we have the oxygen dissolved in the plasma, which is usually very small and essentially is negligible. So that term of this equation is usually ignored. In this situation, your cardiac output is basically your flow. That's how much blood you're pumping out. So what you can see here is the delivery of oxygen is dependent on cardiac output and oxyhemoglobin. But interestingly, you can see from the formula, you can see oxygen delivery does not have any mention of blood pressure at all. So that's interesting. So we all know that hypotension can cause shock. So how does hypotension actually cause cellular hypoxia if the formula for the delivery of oxygen doesn't take into account blood pressure? How does that happen? Well, the answer isn't that complicated. It is going to require us to think back to some physics. So we have to remember the following relationship: that your blood pressure is equal to your cardiac output times your systemic venous vascular resistance. So as the blood pressure decreases, the body can compensate in one of two ways. It can either, one, increase the cardiac output by increasing your heart rate or your stroke volume, or two, it can increase the vascular tone. Now, this is more commonly done in the arterial system, although there is a small venous component, but it's mostly arterial vasoconstriction. This is essentially Poiseuille's law, if you remember back from physics. Poiseuille's law describes the relationship of pressure, flow, and resistance with fluids, where the flow is equal to the different pressure, the large pressure and the low pressure, divided by the resistance. This concept is definitely very important to consider. When you're thinking of whole body blood flow and local organ perfusion. It's particularly because by changing vascular resistances, organs can regulate local blood flow. So what determines this resistance to fluid flow? Well, you can see here we've got this nice little handy formula here where N is the fluid viscosity, L is the radius, is the length, and R is naturally the radius. So resistance increases with longer tubes, and even more so, resistance increases the smaller the radius gets. And this is exponential because this is R to the fourth power. So a change in the resistance, in the radius of a tube has profound changes on its resistance. This is why, a large and very, very short 16 gauge IV is the fastest way to give fluids or blood, not a central line as you might think, intuitively, it's actually the shorter, larger catheter. So, because of this principle, organs are able to auto-regulate blood flow by changing their vascular tone, or in their case, changing the radius by smooth muscle contraction. So as the blood pressure drops, vascular tone decreases, and blood vessels dilate to encourage blood flow, and then, conversely, blood vessels constrict to decrease blood flow. Makes sense. So this is just a picture of a couple of the tools that we'll be using in the ICU, or you might see in the ICU as we treat as we treat shock. This is a central line. It can be placed in the femoral, subclavian, or intrajugular vein. And you can see here, these are basically large IVs that can be used to not only administer medicines, but also measure other things like CVPs. We'll talk about whether, this is a surrogate measure for preload, and then things like SVO2 or SCVO2. This is a PA or a Swan-Ganz catheter. These are even larger catheters that can be placed basically in the same veins that will ultimately travel through the right side of the heart and lodge or rest in the pulmonary artery. And with these, you can measure the cardiac output, the PaO2 or the true mixed venous oxygen, and the pulmonary capillary wedge pressure. With those, with that information, you can actually calculate the systemic vascular resistance as well. Okay, so we want a framework to help us understand and make shock as easy as 1, 2, 3. So I always think of this pattern. I think it's a very nice, simple way to think of the treatment or the classification of shock. So we're going to think 1 volume, 2 pump, and 3 vascular tone. And what we're going to see is that's going to mirror hypovolemic, cardiogenic, and distributive shock. We often categorize the different types of shock based on the physiologic changes to the preload, cardiac output, and SVR. Thinking back to that formula, blood pressure equal to cardiac output times SVR. So this is our little chart here at the bottom. I'm going to make a real quick aside here. As we talk about preload, you'll often see in these charts CVP or wedge pressure, pulmonary capillary wedge pressure will kind of take the place of preload. For conceptualizing things, I think that's fine. Those are surrogates for left ventricular preload. Although in the real world and statistically, they are probably not very good markers for patients' volume state. Just an aside, just in case you ever see that. Okay, so hypovolemic shock. Hypovolemic shock can be seen in, say, something like severe dehydration or hemorrhage. And as the preload decreases from the volume loss, so does the cardiac output. If you think back to the Frank-Starling curve, the heart has, less, stretch. It's being filled less, and as a result, its contractility goes down. The SVR in this case increases in an attempt to improve blood flow. One side note, and we always talk about kind of sometimes the phases of hypovolemic shock. So, one of the first things that will happen is your cardiac output or your heart rate will actually go up in an attempt to compensate. But then eventually, as you lose more and more volume, the cardiac output decreases and your blood pressure drops. So cardiogenic shock. This is as a result of decreased cardiac output. And as a result, both the preload and SVR are elevated. There are several causes of cardiogenic shock. So, we're talking about cardiomyopathy such as systolic heart failure, a mechanical cause such as acute MR or aortic stenosis, arrhythmias such as VFib or complete heart block, bradycardia and tachycardia can cause it. And looking at our little chart down here, this is the key feature: is the cardiac output is low, and the preload is up. So usually in this case, people will have signs of both left and right heart failure. You might see peripheral edema or JVD, and the SVR is definitely increased as an attempt to compensate. Distributive shock. Distributive shock is characterized by vasodilation resulting in hypotension. The preload is often low, and the cardiac output is typically elevated. While septic shock is the classic distributive shock, there are many other less common causes. So you could have anaphylactic shock, neurogenic shock, endocrine such as adrenal insufficiency, or there are certain drugs that can cause this as well. So looking at our chart, this is interesting because this is one of the only ones where the SVR is low, and that is the classic hallmark of distributive shock, is that your body loses its ability to vasodilate and thus causes the hypotension. You get, as a result of that, a little bit of your preload. You lose preload too, and then and also your cardiac output attempts to increase in compensation. Okay, now you might be thinking back, well, we said shock is as easy as 1, 2, 3. You're adding in a whole separate step. This is step 4. This is an interesting, this is obstructive shock. Obstructive shock is typically as a result of an extracardiac pump failure. So there's something causing poor right ventricle output. So despite the fact that on physical exam there may be signs of heart failure such as JVD or peripheral edema, the LV preload is typically decreased and SVR is increased. And it looks actually a little bit like hypovolemic shock. So you can see down here your cardiac output is low, your SVR is high in an attempt to compensate, and your preload in this case is low because something is obstructing blood or fluid from flowing from the right to the left side of your heart. Causes can be divided into 2 categories, pulmonary or cardiac, and in those categories are things like pulmonary embolism, severe right heart failure, tension, pneumothorax, pericardial tamponade, restriction, and constriction of the heart. And one point to make down here is that obstructive shock typically is immediately life-threatening and needs to be identified and corrected as soon as possible. Okay, moving on to treatment shock, which again is as easy as 1, 2, 3. Step number 1, you're going to administer IV fluids until your intravascular volume is replete, and you can use whatever tool you want to help assess that. That might be your physical exam, your CVP, or your SCVO2. It may be using a bedside ultrasound or a passive leg raise or fluid challenge. Step number 2 is you want to assess the heart and decide if this is someone who needs inotrope or even mechanical cardiac support, such as an intra-aortic balloon pump. And then step number 3, you want to administer vasopressors to correct low vascular tone. So these steps, 1, 2, 3, can be accomplished in just a matter of minutes, all while looking for correctable causes for the patient's shock. Those causes might be bleeding, and they might need surgical intervention. They might have an MI and need aspirin and a coronary intervention. They might have sepsis, from an infection, which needs antibiotics and maybe even a surgery to remove the source of infection. It might be definitive treatment for obstructive shock. So you might be looking for a pneumothorax, and they might need a chest tube, or they might have a large, pericardium and need a pericardiocentesis. Remember, the key is to always go in order, steps 1, 2, 3, and never skip. One of the worst things you can do is, skip steps 1 and 2 and slap someone on vasopressors when they don't need it. Let's say somebody comes in with an acute GI bleed, or they're just dehydrated. Their body is already increasing the cardiac output as best as it can to try to compensate. They're trying to, squeeze down the blood vessels as much as they can to kind of help regulate organ perfusion. So the last thing that you want to do is come in, on top of that and give them even more pressures to clamp down even more, because a lot of times all you're going to do is exacerbate end organ damage. You're going to really clamp down on those blood vessels, and you may even cut off blood supply to things like their bowel, and they could get ischemic, bowel from it. So you always want to remember to go through the steps 1, 2, and 3. Okay, if you guys have questions at this point, I'm hoping that you kind of gotten a little bit more a clear framework to help understand shock, and you'll see a lot of it on your ICU rotation. So make sure you ask your attendings or your fellows, kind of what their thought process is as they're going through and treating it. Good luck out there, guys. Thanks.